This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Air Freshener. Want to know what antidote is getting more attention on social media than the poison it treats? What happens if the doctor panics while giving it? Why people are drinking fish tank antifungal cleaner? Listen to find out. Today's episode starts at a party. Your friend from medical school has rented out a big house for a week at the beach. You've taken a few days off to hang out with old friends and to meet new ones. After dinner on Saturday night, you're sitting on the deck enjoying the ocean breeze and catching up. Suddenly, there's a commotion, then a shout for help. You run inside the house. One of the guests is laying on the couch sweating. His skin is blue-gray in color. There are a lot of doctors at this party, but you're the only emergency medicine physician. You look up to see everyone looking at you, waiting for instructions. You don't know this man well. He's the friend of your friend. You do know he was healthy enough to teach you and the others how to surf this afternoon. Question number 1. What is the first thing you should do? A. Call 911. B. Give him syrup of Ipecac. C. Drive him to the hospital immediately. D. Help him upstairs into bed. The answer is A, call 911. If you said drive him to the hospital yourself, partial credit because in truth this depends on the EMS response time. We don't use Ipecac anymore as poisoned patients can aspirate vomit into their lungs, making the situation worse. But this patient looks cyanotic, i.e. blue-gray skin, and I'd be very concerned that his oxygen levels are low. If you put him to bed, you might have killed the patient. As I said, he looks like he needs oxygen, and therefore I'd prefer to have EMS transport him. But if you're in the middle of nowhere or in the middle of a natural disaster or something else, and you can drive him more quickly than EMS, then that's the better option. While you wait for EMS to arrive, you ask him what happened. He says he was fine until about 30 minutes ago when he became very dizzy and lightheaded. He felt some chest pain. He started sweating and thought he was going to pass out. You ask if he felt short of breath. He says no, which is strange given that, as I've said, he looks cyanotic. The medics arrive, transfer him to the stretcher, and hook him up to the monitor. His vital signs are as follows: temperature 98.6 Fahrenheit or 36.9 Celsius, heart rate 115 beats per minute, blood pressure 110/70, respiratory rate 20, and oxygen saturation is 84% on room air, which is obviously quite low. The medics put an oxygen cannula into his nose and give him 2 liters of oxygen. His pulse ox doesn't improve, so they turn it up to 4 liters. They click the stretcher into place and wheel him out to the ambulance. Just as they do, he starts convulsing with violent generalized tonic-clonic movements. This is a seizure. Good thing you elected to call EMS rather than drive him yourself. The medics give him lorazepam, i.e. Ativan, a benzodiazepine, to stop the seizure. They change him to an oxygen face mask to administer 100% oxygen. You note that his oxygen saturation still doesn't improve. What is happening here? It's not clear. What is clear is that he needs to be in the emergency department, not the vacation house. You grab the patient's husband and race to your car following the ambulance. En route, you ask his husband about the patient's past medical history. He says the patient is 34 years old, otherwise healthy, and doesn't take any medicines. They did have a few drinks this evening and ate a marijuana edible, but that the patient was perfectly fine. He's never had a seizure before as far as his husband knows. The husband is answering your questions with tears streaming down his face. He asks what happened, and you respond with, "It's too early to know," rather than answer, "Who the hell knows?" In the emergency department, the patient is lethargic but opens his eyes at the sound of his husband's voice. You're relieved the seizure stopped. The lethargy could be a postictal phase common after a seizure or due to the lorazepam the medics gave to stop the seizure, or due to whatever caused this sudden illness. In real life, you probably wouldn't be taking care of him, but this is fiction, so it's up to you to figure out what the heck is happening. You examine the patient. His heart rate is fast, but it's otherwise normal. His breath sounds are equal bilaterally. His lungs are clear. It's difficult to get a good neuro exam because he's lethargic, but he's moving all of his extremities and doesn't have any focal findings. In medical jargon, that means we can exclude an abnormality, but nothing is obviously wrong. The nurses, of course, repeated vital signs, confirming what the medics found: no fever, a normal blood pressure, and the mild tachycardia. Notably, the patient remains hypoxic with a low oxygen despite getting 100% oxygen. Why? That's what we have to figure out. Breathing has 2 parts, ventilation and oxygenation. Ventilation is the process of inhaling and exhaling. We talked about paralytics causing respiratory failure and opioids reducing the drive to breathe from your brainstem. He's breathing at a normal rate and he has a good effort. Asthma and bronchitis cause airway narrowing, keeping air from getting in, but his lungs are clear without wheezing, so it's not those. Oxygenation is getting oxygen from the air into the bloodstream. Congestive heart failure is when your heart can't pump well, causing reduced blood flow as well as fluid buildup in the lungs, resulting in low oxygen. Fluids in the lungs cause the sound of crackling, which again is absent here. Blood clots, pulmonary emboli could cause this, but this isn't a pulmonary podcast, it's a toxicology one, so I'll skip ahead and tell you his chest x-ray is negative and a CT scan shows no blood clots and no other lung pathology. Let's move right ahead to toxins impairing oxygenation. Exposure to carbon monoxide causes asphyxiation. Chlorine gas causes pneumonitis or inflammation of the lungs. Smoke inhalation damages the lungs via many methods depending on the nature of the smoke. Metal fume fever from welding zinc without proper protective equipment is due to inflammation. Hypersensitivity pneumonitis can occur from things like exposure to fungi like aspergillosis. Lots and lots of drugs can cause acute respiratory distress syndrome or ARDS, which is irritation and inflammation in the lungs. But it causes changes on X-ray and more importantly develops over hours or more commonly over days. So honestly, none of these fit. There are a lot of interesting toxins with interesting pathology, but we don't have all day, so let me sum it up with the following. Very few things cause a low oxygen in and of itself without pulmonary edema or fluid in the lungs, bronchitis or wheezing, or findings on chest x-ray. The other element you need for oxygenation is hemoglobin. Hemoglobin inside the red cells are what carry oxygen to the tissues. If you don't have enough hemoglobin, you won't have enough oxygen. Now, this doesn't happen with mild anemia, and even patients getting blood transfusions typically have normal oxygen saturations. One problem causing a sudden issue with hemoglobin and oxygenation is hemolytic anemia or breakdown of your red blood cells. G6PD is an enzyme deficiency. If patients are exposed to an oxidizing agent like fava beans, it can trigger hemolysis. It's a hereditary disease. Any chance our patient could have previously undiagnosed G6PD and eaten fava beans? Well, it's possible, but it's not likely that this would present in adulthood rather than childhood. And we'll find out because we'll be able to tell from his blood tests. The nurse adjusts his oxygen mask and his pulse ox again, but nothing changes. There is one test which I would send immediately, and in a nice change from our usual toxicology expectations, it's actually a quick test, even quicker than a blood count and electrolytes. Question number 2, what's the test? A blood glass, B, a D-dimer, C, a co-oximetry, or a co-ox? The answer is C. We need a co-ox. It will test for oxygenated and deoxygenated hemoglobin, carbon monoxide, and methemoglobinemia. A blood gas measures the pressure, i.e. levels of oxygen and carbon dioxide dissolved in the blood. So we'll get a blood gas with the co-ox, and you can use either an arterial or a venous specimen. A D-dimer is an inflammatory marker we use for pulmonary embolus, which we've already excluded. Could this be carbon monoxide poisoning? It's a great thought, and I'm sure you've read about people dying from carbon monoxide in vacation homes and hotels. Carbon monoxide can cause seizures and hypoxia, but it isn't likely here. Why? Because everyone in the house, including you, would be sick. The co-ox takes just a few minutes to run, and you get the results back immediately. His results are as follows. Oxyhemoglobin 97%, carboxyhemoglobin 2%, so no to carbon monoxide toxicity. His methemoglobin level is 42%. Does this explain his symptoms? Yes. He has methemoglobinemia. Most toxicologists and many astute EM physicians would have guessed this. There are 2 clues. First is the refractory hypoxia. ED patients routinely have hypoxia, i.e. low oxygen. And of course, it's very life-threatening, but most of the time it gets better with oxygen. And second, his skin color. I just said hypoxia is common. I see it every day, multiple times per day in the ED. And even patients with pulse oxes in the 80s, like some people with COPD or emphysema, live at those levels. But none of these patients have blue skin. The patients with cyanosis are the patients in cardiac arrest. So this skin color is way out of proportion to his oxygen saturation in the 80s. A quick aside to explain how we measure oxygen saturations with a pulse ox. It works the same way in the hospital or at home if you measured yours during COVID, for example. The pulse ox is a colorimetric measure, meaning it measures the wavelength of the blood. And normal oxygenated blood is a certain color corresponding to a certain wavelength. Nail polish can interfere as well as a few other things, but generally it's a great test. So how do we explain the discrepancy we're seeing on the monitor reading a low oxygen saturation, but the blood co-oximetry showing that his blood is 97% saturated with oxygen? Well, his problem is that 40% of his hemoglobin has been converted from oxyhemoglobin to methemoglobin, and methemoglobin can't carry oxygen. In addition, methemoglobin is blue, changing the color and the wavelength of the blood. This means with methemoglobinemia, regardless of the actual level, the pulse ox usually registers in the mid-80s. All right, so first, what is this problem, methemoglobinemia? The entire thing is caused by a single electron in the wrong place. In the setting of an oxidizing agent, more on that in a second, the iron in hemoglobin goes from Fe+2 to Fe+3 because it loses an electron. It becomes methemoglobin. Doesn't sound like much of a change, but it's huge because oxygen can no longer bind to the hemoglobin. What kinds of things cause methemoglobinemia? Well, local anesthetics are a very common cause, things like lidocaine creams or benzocaine sprays. If you ever see a few-day-old infant with methemoglobinemia, classically, dad is a urologist who's been applying copious amounts of lidocaine cream after circumcision. Antibiotics like dapsone and rifampin, they're rarely used these days to treat leprosy and tuberculosis. Some antimalarials you might have heard of or used yourself, phenazopyridine, which is brand name Azo in the US to help treat a urinary tract infection. The box says not to use it for more than 3 days, and this is due to the risk of methemoglobinemia. Mothballs with naphthalene and anything with nitrates can cause it as well. Question number 3. Exposure to the following causes methemoglobinemia in infants. A, cow's milk. B, honey. C, well water. D, juice. The answer is C, well water. If you have an infant with methemoglobinemia, well water used to mix the formula can be a culprit. Why? Well, wells can become contaminated with nitrites from fertilizer, and infants are particularly susceptible until they're about 6 months old because bacteria in their GI tract convert nitrites into nitrates, which, as I said earlier, can cause methemoglobinemia. What are the symptoms of this problem? Well, there's a strong correlation with the actual blood level. So anybody can have a level of 3% or so. It doesn't cause any symptoms. And in fact, most patients don't have symptoms until a level of about 15 or 20%. Then you'll see blue-gray skin discoloration. With levels from 20 to 50%, patients complain of dizziness, shortness of breath, headaches, and weakness. They might pass out. At 50 to 70%, you see altered mental status, seizures, dysrhythmias, and death. And above 70% is generally inconsistent with life. There is a caveat. If patients have a baseline anemia, they might experience symptoms at lower methemoglobin levels. All right, back to our patient. We've diagnosed the problem. How do we treat methemoglobinemia? Is there an antidote? Yes. And a big hint, the antidote is getting a lot more social media and press attention lately than methemoglobinemia itself, especially in the United States. Question number 4. Is the antidote A, B12 or pyridoxine, B, methylene blue, C, vitamin D, or D, fish oil? The answer is B. The antidote is methylene blue. First, let's talk about it as an antidote, then we'll come back and talk about all the stuff swirling around, including how it became a nootropic. Methylene blue is FDA approved for one use, and that's as an antidote for methemoglobinemia. It's very safe and effective. For mild methemoglobinemia, removal of the offending agent is the only treatment necessary. This generally works for patients with levels of 15 to 20%. Levels of 30% or more should definitely be treated. As I said, methylene blue has few side effects. The main one is blue urine. The dose is 1 to 2 milligrams per kilogram, and most patients improve immediately. If after 30 to 60 minutes they haven't, you can repeat the dose. There's only one big risk, and that's if the doctor or the provider panics. That's really the main route to a bad outcome. What do I mean? Whenever recommending methylene blue, I always take the time to explain at great length what happens during the infusion. I've already said patients typically have SATs in the 80s, and I've also already said the pulse ox is a colorimetric monitor. Methylene blue was originally a dye, you guessed it, blue colored. So when you administer methylene blue, the patient's blood changes color, and specifically the pulse ox drops because the monitor thinks that the patient has blue deoxygenated blood. In reality, though, their oxygenation is improving because you're getting rid of methemoglobin and putting that electron back where it belongs, thus allowing oxygen to bind to their now back to normal hemoglobin. Every single time I recommend giving it, I warn the provider about the pulse ox dropping and warn them not to panic and intubate the patient. More than once, I've called back to check in and found that the patient was intubated and on a ventilator in the ICU. Now, to be fair, it's easier said than done to stand by, afraid your patient is worsening and doing nothing. In almost every other case, if you stood around watching the pulse ox drop doing nothing, that's malpractice. I've been at the bedside many times myself, sweating it out. But as long as the patient's clinical status doesn't worsen, you just have to wait. The real risk with this antidote isn't the drug itself, but with the providers overreacting. So if the methylene blue doesn't work, well, you probably have the wrong diagnosis. Somebody told me about a case where the patient stayed blue and no one could figure out what was happening. The next day, the patient's father walked into the room. He was also blue. Neither the patient nor the father was poisoned, but the family had hereditary methemoglobinemia due to hemoglobin M genes. It was discovered in a family in Kentucky called the blue fugues, and it was the result of a very, very recessive gene. The fugues were otherwise healthy, and most of them lived well into old age. Anyway, back to our patient. He's now alert since the postictal phase and the lorazepam wore off. You order 2 milligrams per kilo of methylene blue. You warn the nurse and the patient's husband about a transient and not real pulse ox drop. 15 minutes later, his pulse ox is 76%. You clench your hands inside the pockets of your white coat and grit your teeth. It's hard to stand there waiting, even when you know better, when your instincts are shouting at you to get an airway box and a ventilator. You ask the patient how he's feeling. He says he's feeling better. And in 15 minutes, he's back to baseline with a pulse ox of 95% and a urinal full of blue urine. Methylene blue is FDA approved as an antidote for methemoglobinemia. It's used off-label for vasoplegia, which is refractory low blood pressure during heart bypass surgery, and it has been used for sepsis, though this has fallen out of favor. As I mentioned earlier, the antidote has been getting more attention than the toxin recently. It's been all over social media since Robert F. Kennedy Jr. was seen in a video with a glass of blue liquid presumed to be methylene blue. This started a social media craze with influencers sticking out their blue tongues after drinking it. In the arena of so-called wellness influencers, I'm using the term loosely, it's been touted as a nootropic. Full disclosure, I had to look up what that word meant since I've never heard of it before, and it's a substance reportedly increasing cognitive function. There are a wild number of claims touting methylene blue as a cure for just about everything, including Alzheimer's, memory loss, and aging itself. We always stick to the facts here on this podcast, and none of those claims are proven. You might find some data in a very small study with a few humans or a few rats showing a benefit, but you can just as easily find other studies with conflicting data showing a lack of effect of methylene blue as a nootropic. There is evidence it might be useful in depression, though that's also far from proven. One of the issues is that methylene blue can cause serotonin syndrome in combination with other drugs, particularly SSRIs. And obviously, people with depression are commonly on SSRIs, so the risk-benefit analysis really isn't in favor. What methylene blue definitely does have is antimicrobial activity. Kind of a side note, but really interesting, is that many modern pharmaceutical companies, Bayer, for example, began as dye companies in the 1800s, like dyeing fabric and clothes. Several dyes were noted to have antimicrobial activity, and methylene blue was the first to have significant medical use. It does kill some bacteria, fungi, and malaria, and it was used as an antimalarial and an antibacterial, though this was brief. Sulfanilamide displaced it, becoming the first real antibiotic, and sulfanilamide, too, is derived from an aniline dye. Interestingly, in the past, methylene blue was used to test milk. If the milk stayed blue, it was bacteria-free. If the methylene blue dissolved and the milk turned back to white, it meant bacteria were present, which is kind of cool. Some people ordering methylene blue online in the present day are accidentally consuming fish tank cleaner because it's used for its antifungal properties. Consider yourself forewarned, because who knows what else is in with the methylene blue if you drink fish tank cleaner. All right, so we know our patient has methemoglobinemia. We've successfully treated him with methylene blue. Will he require additional doses, and will his symptoms come back? Well, in order to answer that question, we need to know what caused it. If he was exposed to something with a long half-life, it could come back. If it was something with a short half-life, he should be fine. Dapsone, an antibiotic we used to use for leprosy and occasionally still use for other causes, doesn't typically cause high levels of methemoglobinemia, but the levels can last for several days even after cessation. The real question is how our patient developed methemoglobinemia. You step out to deal with some pressing issues on other patients, and shortly thereafter the nurse calls you back into the room. The patient sheepishly says he took something he bought in a gas station. Uh-oh, we had a whole episode on gas station medicine, and even so, we barely scratched the surface. Question number 5, and time to pick your poison. The toxin he got from the gas station was A. Kava Kava, B. Kratom, C. Anabolic steroids, or D. Poppers. The answer is D. Poppers. He says he picked up a bottle of Rush. If you grew up in the 90s, you probably know it's one of the names Poppers is sold under. The actual ingredients vary, as with most unsupervised gas station preparations. They typically contain a nitrate, The composition varies regionally and over time with drug enforcement and legal issues. Amyl nitrate was the most common. In the US, this was banned, and now butyl nitrate is more common. It's the nitrate itself that acts as an oxidizing agent, causing the shift from hemoglobin to methemoglobin. In the US and in other places, nitrates exist in a legal gray zone. It is legal to use and sell them as air fresheners, liquid incense, nail polish remover, and shoe cleaner, despite the fact that they are almost never used for these reasons. They do have a very strong, distinctive smell. Typically, a bottle is opened and the nitrate diffuses into the air in a nightclub or a party. Why? Users report feelings of relaxation and euphoria without any true altered mental status like other drugs. Another big draw is they cause smooth muscle relaxation, including sphincter relaxation, facilitating, shall we say, the party atmosphere. You find the information he used to popper surprising. You were there and didn't smell anything other than the ocean, and you certainly weren't affected. Sure, you were sitting outside, but you should have smelled something when you went in to help. Also, he was really sick with a seizure and a very high level. I've seen tons of patients with mild symptoms and mild methemoglobinemia after inhaling it at a party. Most are observed and discharged after a few hours. Why was his level so high, and why was his husband, who was in the same room as him, totally fine? The patient says it was a small liquid bottle about the size of an energy shot labeled Rush. After a bit more discussion, the patient says, "Wait, what? Aerosolized?" Now you have a good guess as to what happened. That's question number 6. A, the patient was too close to the bottle. B, he drank it. C, he injected it. The answer is B. He was unaware that typical use is aerosolization. It looked like an energy shot, so he drank it, which explains why his level was so high and why everyone else was fine. Poppers have a long history of use. Amyl nitrate was discovered in the 1800s and initially used to treat angina or cardiac chest pain. At the time, it came in an ampule that had to be popped open, thus the name. Even in modern times, amyl nitrate is still in ampules. We talked about cyanide toxicity a few episodes ago, and I talked about the old Antidote kit, which was a 3-step process. The first step was amyl nitrate in an ampule, meant to be popped open and waved under the patient's nose until you obtained IV access for the other 2 steps. I've seen a ton of cyanide antidote kits opened for teaching residents and fellows. I think I've only seen 1 or 2 amyl nitrate ampules. The others were all suspiciously missing. Poppers were popular with men having sex with men in the 1970s and 80s because of the sphincter relaxation aspect. They became popular again in the 1990s at raves and are currently having another resurgence. Our patient thought it might be fun to try a popper for recreational reasons, but unfortunately didn't read the instructions, resulting in a night spent in the hospital rather than a relaxing evening on the beach. Fortunately, he makes a full recovery. He doesn't require additional doses of methylene blue. He has no sequelae, and all of you are able to get back and enjoy what remains of the weekend. This is a fictional case, as are all our cases, but it is based on real poisonings. The last question in today's podcast. Poppers were blamed falsely and bizarrely, I might add, for what epidemic? A, COVID, B, AIDS, C, Ebola, or D, the swine flu. Follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for listening. It helps if you subscribe, leave reviews, and or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.